So I want to cover the radiographic guide construction, just because if this isn't built properly, then that third method won't work. This is an example of a very nice looking surgical guide, or radiographic guide. It's built really nice, and I'm going to go over the different details on why. But this is kind of an older technology. This is not a good radiographic guide to use. And I want to show you why, because I know there are some people in labs out there that are still using this type of technique, but it is outdated. And the reason is this concept came about, it was a great idea, is when you scan the patient wearing the radiographic guide, you can't see the radiographic guide because it doesn't have any radiopaque substance in it. So what they decided is that they take an 8 to 10% barium mixture and create a crown with a really nice anatomical wax up, and it's in the ideal shape and location of a crown. Then when they scan the patient wearing it, you can see the crown. And then you can place the implant, and you can see how the implant emerges, the emergence of the implant through the restorative space really clearly. So, but I'm going to show you why that's a problem and a latest solution to that. So what we're looking at, again, is if we look down at the bottom, we see a little section of a Panorex there. And we're going to look at the yellow middle slice here. We're going to pull that out and lay it flat above there. So what we're looking at is you have a density in the bone, which represents the adjacent dentition, the distal edge of that natural adjacent dentition. And then as we go up, we see these bright white areas of these bright densities, and that represents the mesial edge of that barium tooth. And so if we evaluate the bone in this area, we see on the buccal that there's significant bone loss at the buccal crestal area. And but knowing what I know about cone beam images and how a radiopaque substance affects cone beam images, I had them remove the barium guide and take another CT scan on the patient. And so we did that. It was the same patient, same type of CT scan within a week or so. And this is the new image. And you're gonna see that there is no bone loss on the buccal plate of bone. It actually is really solid. You have cortical plate that runs all the way up to the cortical plate. And the reason that it looks like it gives us the illusion in the first one that there is bone loss on the buccal coronal aspect is because we're looking at a volumetric shadow here. And what that is because we have this really high density. It's contrasted with this really low density. So I like to compare it to when someone takes your picture and that bright flash for the next few seconds, all you can see is a square representing that bright flash. So conceptually, this is the same thing. We have this bright area, and we're going to have this dark shadow. And just as the picture, when you see the dark square, you know that there's stuff behind it. And that's the same with the CT scan. We know there's anatomy behind that volumetric shadow. We just can't see it because it's a static image. The other thing that I want you to notice is in the beginning I said that one of the CT advantages to CT imaging is that there's that it doesn't affect, a high density doesn't affect the entire scan. Well, the cone beam, it does affect the entire scan. And you'll notice if you look at the trabecular pattern or the medullary bone space on both of these cross-sectional images, you'll notice the one without the barium, it's much clearer. And that's very critical, especially for a mandible if we're trying to look and see the canal and mark the canal. Especially in this case, it's really tough to see. It's marked slightly down here, but those cortical outlines aren't really well defined. And so it's really nice to have a better image that way as well. So that's why we don't want to use barium. There's other guides that are built as well. We use little tiny gutta percha markers. This particular guide, somebody wanted, and it's another great idea. They're gonna place the barium at a vertical angle that projects the ideal profile emergence of the implant through the restorative space. And so there's these long vertical lines of gutta percha. The only problem with that is instead of them being small dots, when we merge the two we scan the patient and then we scan the guide by itself, and then we merge those two together. And when we merge those two together, there's a variance of, or discrepancy of this entire vertical length. And you can see that in the cross-sections below. The outline of the yellow here represents the guide. And you'll notice that on the facial plate of bone, it doesn't go through the bone on the first image, and it does on the other image. And that's just because it's moving up all those different points that are available through a long vertical tubular shape of gutta percha there. So the models, as you can see, are so critical to be able to treat the plant surgically properly and have the restorative advantages. If you want us to build your model for us, we can. Otherwise, we can train a local lab. It's a pretty simple translation for them to do it as far as building a radiographic guide. When you get your radiographic guide, you want to make sure it seats properly, it doesn't rock or move. One of the big problems that we've seen is, even though it's surgery, your surgical guide, the patient's not going to be occluding. At the time of scan, the patient's going to be occluding. And if they get nervous and they clench and they grind, and if that radiographic guide isn't supported both on the buccal and the lingual, then they could possibly shift the placement and location of the radiographic guide. So when it's built, it should cover the entire occlusal surface and have supporting acrylic on both the buccal and facial, so that there's no way that it can move, even if they do clench down during the scan. Should be rigid material. Gutta percha marker plates are important. If there are any more, if there's too much in the occlusal area and there's a lot of densities there, they can get lost in the occlusal area and we can't pick them out. So you want a deep lingual flange for us, and then place them right at the bottom in the vestibule area so that we can pull them out pretty clearly. So these are two really well-built surgical guides, or radiographic guides, that illustrate how they should be properly built. You can also do a duplicate denture as long as it's hard-lined and it seats well. I always suggest a duplicate denture and ice denture. And I'll show you why, but you can have the lab adjust it so you have ideal tooth location. So Link's Dental Lab provided us some pictures. They took some pictures as they went through and built a radiographic guide. And so this is going to help as far as, with labs. And this is the type of, I get a lot of labs actually asking me, what do you use to build it? What type of material? And you don't want to be sucked down. It can't be flexible. It's got to be rigid, and this is good material to use for that, the denture resin. So again, Link's Dental Lab provided all these images for us. We start with a model, and then they block it out. They do a duplicate denture. They do a wax prep, and then there's acrylic tooth in the edentulous areas. So we can have a nice anatomical wax up in that area. And then they putty, they put the putty on, boil it out, and then cure it. And so then we have our radiographic guide. And they use the model, make sure it seats properly and then polish it out. I'm using a 1 millimeter burr, and they drill in 1 millimeter. And this particular lab uses this type of gutta flow, but you can use any type of, I would suggest metals, but you could do gutta percha, you could do, I've seen them do it with barium, that works fine. So any type of radiopaque substance in that area. And then this is the final guide. You'll notice that they put little holes here, so when you seat the guide, you're able to see that it's seating properly. And sometimes if it's really, there's a lot of restorations and a lot of noise, sometimes it's nice to put in an extra gutta percha marker in case we're not able to see it. So 6 is the minimum, but 8 is fine. So the way that we use this, so it complements both the restorative and the surgical, is we do a dual scan technique. Basically, we scan the patient wearing the radiographic guide, and you can see in the image that the only radiopaque substance in the radiographic guide are the 6 gutta percha markers. So when you scan the patient, you're only going to see the gutta percha markers, as we see here. But the second scan is of the radiographic guide only. And the reason we're able to pick up a digital duplicate of the radiographic guide without any barium or any type of radiopaque substance is because we scan it alone. We actually set it on a piece of foam so it looks like it's floating in the gantry. And the scan will pick up the density comparative to the surrounding densities. And since there's no surrounding densities, it's able to pick it up and scan this image. It just can't. It's got to be by itself. So the common denominator between the two images is those radiopaque substance, those gutta-percha markers. And so we just merged those two together. And the nice thing about this is there's no radiopaque effect on the bone, especially in the surgical area. So you're going to see the bone really clearly. But also, if we build your radiographic guide to those proper ideal tooth locations, then you don't need to see the opposing arcs. You just use the guide as your ideal tooth location. So restoratively, it's really great that way.